Well, good afternoon, everybody. I'm delighted to welcome you to this Neurology Academy webinar, Innovating Headache Care, Service Setup and Redesign Benefits. My name's Sue Thomas. I'm going to be chairing today and speaking briefly, and I'm going to be joined by Siobhan Jones for this first part of the meeting, who's going to be talking about her service. Just to do some housekeeping details to start. The webinar has received sponsorship from Teva UK Limited, and it's been developed and designed and delivered by the Neurology Academy. The sponsor has had no input at all into the educational content or organisation. So this is the two of us. Siobhan will introduce herself shortly when she speaks, but Siobhan is a headache nurse consultant in North Cumbria, and highly experienced at service innovation within her area and nationally. So our objectives for the meeting really are to highlight how headache nurse specialists can improve the management of care for people with headache, detail how her post has been established in her own local area, and then provide some case studies from clinical practice. I just want to flag the fact that headache is now a national priority within neurology services nationally, and we have established with the National Clinical Director for Neurology a headache transformation masterclass, which is going to be looking very much at how we can actually develop services within our own local areas. The programme is a very interactive training programme around service development. There are two modules to it. It's actually fully sold out at the moment, but there is a waiting list if you are interested in being on that waiting list, because I'm sure that once we've delivered this first course, there will be subsequent courses that take place. But if you want to scan the QR code on the screen, you'll be able to get further details about the masterclass. And additionally, annually, we've been holding a National Neurology Transformation meeting that's detailing just how neurology services are changing for the future. And if you want to attend that meeting, it's open for registrations at the moment. It's going to be held on the 4th of February in Birmingham. We've got some really brilliant national speakers who were speaking at that meeting. The meeting is free to attend, and the QR code to be able to attend it is also on the screen now. So if you wanted to scan that, you'd be very welcome to come along to that meeting to hear about how neurology services are transforming for the future. And I'm going to just set the scene to start the webinar off, so that there is a little bit of background around why we need to innovate on headache care and around service setup and redesign benefits. So these are my disclosures. And I think one of the first things that I want to point out is that we've got major changes at the moment within the NHS and neurology services in the way that they are being delivered. So I'm sure it's not escaped anyone's notice that we now have the Fit for the Future 10-year health plan for England that is really trying to look at how we can improve the services that are being delivered in the NHS at the moment. We've also, alongside that, got the Neurology Service Transformation Programme. And for the past couple of years, we've actually been re-looking at how neurology services have been delivered because they were not fit for purpose. And there is now a transformation programme that's running. We've got an integrated neurology service delivery model. We've got different toolkits that are available for integrated care boards to be able to develop services and look at how they need to be delivered for the future. And all of this information you can find on the Neurology Transformation website, which is part of the NHS Fit for the Future website. So there are the links there that you can find this information. But basically, Fit for the Future, the 10-year plan, has highlighted 3 shifts, and those 3 shifts apply to headache services as well. So that is from hospital to community, where we are now looking at neighbourhood health centres with integrated care. We've got the first of those that have been set up. We're looking at analog to digital, so really trying to focus a lot more on that shift to the left to make patients more responsible for their own care and to provide as much of the care that we can through information technology and digital apps. And the NHS app, you may have heard, is becoming the doctor in my pocket and being used for accessing services. We're looking a lot more at remote consultations, artificial intelligence to be able to manage patients. And then that final tranche, that third shift is around sickness to prevention. So policies tracking food consumption, smoking and vaping. And I guess from a headache point of view, it's around looking more at preventative strategies for managing headache occurring in the first place where we can. And the things that are running alongside that in terms of structural reforms are the fact that NHSE is being abolished and there is going to be a Department of Health and Social Care merger. That NHSE abolishment is going to take till 2027 at the moment because of finances, but we are kind of seeing a winding down of that. We're seeing a lot more integrated care board clustering and collaborations, and that move towards neighbourhood care. And just this year in August, we had the Specialist Neurology Adult Services Specification launched. So this is the specification around how neurology and headache services need to be delivered. The prior specification that we had was actually published in 2013, so it was very much out of date, and it really incentivised us to manage patients that had got headache and other neurological problems within neuroscience centres. But now there is this move, as I said previously, around this shift to the left to try and get more care into the community, to have more care provided at a neighbourhood level. So the specification itself provides what needs to be the structure, the expectation and the outcomes of neurology services for the future. And for the future, we're looking at delivering neurology and headache care through joined up integrated neurology systems for populations of between 1 and 3.5 million. So unlike the hub and spoke models that have previously been mentioned around delivering neurology services, the integrated neurology service is designed to integrate services between primary, secondary and tertiary care, still maintaining accountability through the specialised systems. The website for that specification is also on the screen there if you want to have a look at it. But the whole idea now is that there is a core strategic plan around how those services will be delivered. And from this diagram, you can see that the majority of care for patients with headache for the future needs to try and be within this outer core neurology services circle. So that's primary, community, secondary and inpatient care, as much as possible out of hospital care. And where possible, sending patients really only to the specialised neurology services where they can't be managed within primary care. So that's going to be the future, really. And the whole focus of today is really to try and show you how that's already occurring with some of the services that we have at the moment. This is a rather busy diagram that I've constructed, but previously, I think, in terms of the delivery of care, a lot of services, GPs and primary care networks, have sent patients directly towards the specialist headache services within neurology centres. But for the future, we really need to look at that total pathway of care that patients are travelling. So in terms of the neighbourhood and our GPs, really try and prevent headaches from occurring in the first place. So looking at how we can support people in schools and the workplace in order to identify potentials for headaches occurring, looking at people like health coaches and social prescribers and the voluntary sector that can support work around that to try and support people with any headaches they might be getting, looking at community pharmacy perhaps as a one-stop shop. Where people do have headaches, it's actually sending them to perhaps a GP with special interest who will be able to support those patients and diagnose them at an earlier stage, to diagnostic hubs or to community headache clinics where we've got GPs with extended role and headache nurse specialists who can support patients and make diagnostic decisions within that primary care environment. So that in our top circle there, the red circle that we've got, which is our specialist headache service, we have the minimum number of patients going there. And by doing this, we will hopefully reduce the waiting list times for people to be seen, which is huge at the moment, and get a lot more people seen at an earlier stage. Not forgetting along the lines that we've got the community and voluntary sector in here that might be able to provide much care in terms of neighbourhood networks, in terms of giving people advice. And then where we've got patients going into hospital with headache who perhaps potentially think they're having a brain hemorrhage because they've got a headache they can't control, we try and reduce that demand on hospitals as well by getting that earlier intervention in place. I think the burden of headache and migraine nationally is largely invisible, and I know Siobhan will be giving you some statistics about how many people we've got in our communities that are living with this problem. But again, it's something that we need to really start to focus on and bring this into the public health arena, so that we've got population health management, so that we can identify how many people are living in localities with headache and how many we need to be supporting. So this is a kind of a transformation pathway for migraine for the future and how services will look. And I think that, this is very much going to be the future, and it's going to be supported by the current policy that's available to us, particularly with this new neurology specification that we've got. Just in terms of data, I don't know whether you're all familiar, but there is a national ICB dashboard that is available if you've got an NHS login, where you can find out all the information about what impact headache and migraine has in your locality. And you can access that dashboard through the NHS website, the NCDR portal. Again, I've got a QR code on here that you would be able to scan in order to be able to get access to it. So that's a very quick overview of the policy that's surrounding the headache and migraine agenda at the moment. And I'm going to now pass over on to Siobhan to talk to us about how she's innovating healthcare in her own area and has been able to set services up and redesign to provide benefits for her ICB. So Siobhan, over to you.
Thank you. Thanks, Sue, and thank you for the introduction, and thank you for inviting me to talk to you all today. It's a pleasure. Just a little bit of background, I guess, of myself. My background's largely neurosurgery, and swiftly moved to neurology. And my headache journey began almost, I would say, 14 years ago, roughly, maybe a bit more, where I successfully set up the first nurse-led headache clinic at a previous trust in Manchester. And at that time, there was very few headache nurses, fewer than there is now, but very small group. And to have a nurse-led headache clinic was rather unique. So I'm very proud of that. And there is still a very good team there. But then I brought my expertise and experience here to Cumbria. Obviously didn't come here for the weather, but I thought I'd found it another challenge, really, in Cumbria, because it's not as big of a service as it was in a city. But anyway, I'll continue my talk. So yes, innovating headache care, service setup and redesign benefits. So I thought I'd start with the current landscape. You probably are all too aware of this, but migraine affects 10 to 15% of the UK population, 8 million people, absolutely massive amount. And chronic migraine is, disproportionately impacts women and that working age in adults, and those with comorbidities such as anxiety and depression. And it is the second leading cause of years lived with a disability. And globally, is the leading cause in people under 50, which is, again, it's all that sort of working age. And because of that, data has shown migraine accounts for more than 25 million lost work and school days annually. And the economic burden is even worse, at estimated 3.2 billion annual costs to the UK economy. And up to 90% of sufferers report functional impairment during attacks. So when we look at a little deeper in the current headache service that we have from a UK perspective, many patients will obviously attend their GPs, primary care. It's usually the first point of contact for many people, but yet GPs report low confidence in diagnosing migraine effectively. So then comes the over-reliance on over-the-counter medications, and there's that limited focus on actually preventive, evidence-based preventive strategies. So then the patient moves on to secondary care, where they would hopefully see a specialist in headache. But again, the service within this remains patchy and inconsistent. In the GIRFT report, GIRFT Neurology report in 2022, this obviously highlighted this significant regional variation, so referral pathways, waiting times, and obviously hence treatment options. Advanced therapies came along, such as CGRP, the monoclonal antibody treatments, and botulinum toxin, which became available, but again, initiation rates vary widely just due to the resource constraints. And then, as I mentioned at the beginning, headache nurses, we are becoming increasingly recognised as key players in headache care pathways because we provide assessment, education and treatment. But the numbers of headache nurse posts, again, across the UK remain limited. And that's from a geographical inequality point of view. So when we look at the gaps and the inequalities and challenges, it goes without saying there's an access inequality, and urban centres, you know, often have access to tertiary headache clinics, but rural regions like ourselves, the whole of not just North Cumbria, I would say South Cumbria, face longer waits and limited service reach, and this leads to underdiagnosis, undertreatment, and it's quite staggering that then up to 50% of people with migraine remained undiagnosed. So in this sense, those that among those diagnosed, preventative treatments are underused and leading to avoidable chronicity. Goes without saying there's a stigma with migraine and misconceptions, and it's very misunderstood. You know, it's just a headache, you know, and, you know, patients often say very disheartened, you know, even at work, they struggle because it is just seen as a headache and they're not getting the support that they need. So then leads to workforce pressures. There is a shortage of, I would say, manpower, neurologists, headache specialists, and it contributes to this bottleneck. So we need to expand the role of headache nurse in headache nurse consultants, or and have nurse-led clinics, which will offer a solution. So the North Cumbria Integrated Care Headache Referral Pathway, well, yes, initially patients will visit their primary care or GP. And they get initial assessment. Now, you know, there are a few primary care centres that actually, you know, they will manage the foundation of migraine and the treatment, and very simple cases, and they can start them off on a preventative, but quite often this is usually not the case. But we do have electronic referral system if needed, and this goes through to the NCIC triage hub. This is via central review. It goes to prioritize, so it's prioritized, and then the patient is then allocated a clinic. Usually they will come to me if it's suspected migraine, more often than not, whereas an assessment and diagnosis will be made. A range of treatments then are obviously offered, but most importantly, patient education. Because patients need to understand what migraine is. I mean, migraine is complex at the best of times. It is a complex condition. So that's where I usually start with. And then at least the patient then starts to feel a bit of control over their own condition. As you can see there, we can offer a range of treatments, and the vital thing is they're having an ongoing support and reviews, regular follow-ups and action planning. If needs be, if they are more complex headaches, of course, we refer to tertiary centres, and we are lucky to have a team very close by in Newcastle who help with the more complex cases. There are general patient pathways in Cumbria. Again, once the patient has visited the GP, that we do have clinics around, yes, Whitehaven, Carlisle, but it may involve coming back to Penrith, which is the main where the nurse-led headache service is. There is specialist input again, but again, this can be limited. And if like I say, if the diagnosis is complex, we may have to refer, and it involves a lot of travel, you know, going to Manchester, Liverpool, Newcastle. And they've also got a private route. Now, obviously, as you can appreciate, some patients wait years and years and years to get a firm diagnosis, and sometimes private can be their only option. And we do have a direct self-referral, for example, if they should want to see somebody privately. Now, we do offer, or we do have advice and guidance, which I think is really, really useful. So if GPs do have patients with suspected migraine, they can refer via advice and guidance with a basic outline of the patient's history and symptoms, and we're able to advise via the advice and guidance route, so electronically, so we can then advise on management. I feel this is quite effective. This avoids the patient having to then be in a waiting list to come and see me or the headache service. And usually we get back to them within 4 or 5 working days with a management plan. So, for example, start one preventative. If it doesn't work after a few months, start another. And obviously, again, at least there's a plan in place and patients have something to work with. Otherwise, it is a direct referral to myself at Nurse-Led Headache Clinic. Obviously, migraine is complex, and one treatment does not suit everybody. So for recurrent migraine and those refractory headaches, that's the place so my clinic is perfect for, really. And then they can have access then to advanced therapies, such as the injectable treatments, Botox, and the monoclonal treatments and nerve blocks. Of course, we have the general neurology route. So if there are red flags, of course, and it's very obvious it's not migraine, it's more complex than that, then they simply refer straight to the general neurology. But there are longer waits and fewer specialist migraine slots. So the headache nurse consultant led service, I mean, goes without saying that nurses are I'm a bit biased, but the role of nurses are essential in assessment, treatment and patient support. They are the key to long-term management and stigma reduction, and they are essential in delivering high quality patient-centered migraine care. Within the patient assessment and diagnosis, you know, taking that first history, the comprehensive headache history is priority. I think you get a lot from that very first consultation, and if that's done right, the rest of it is pretty straightforward. Once you have that confirmed diagnosis, then, you know, ruled out red flags, then it's time to then you know, educate the patient, then put them on appropriate treatment. And yes, you know, we start evidence-based treatment. We're able to monitor the effectiveness and side effects. We're not just prescribing a medication and sort of saying, right, see how you go, that's it. You know, So there's a team or a team effort, because I think that's really, really important for patients to engage. Otherwise, it's very easy for patients to try a medication for a few days and say, well, it's not working. But it's not a case. They have to try and persevere for a few months to see any results. So as I've mentioned, patient education and also lifestyle. It's not all about the treatments. It's about, might having to adapt to a different lifestyle to avoid having as many migraines. So it's migraine triggers, obviously medication overuse, which is very commonly seen in clinic. Medication overuse is by far the most commonest presentation due to the fact that patients are in pain, so they're going to take painkillers, but then they end up in a vicious circle. Self-management tools, headache diaries, so then patients themselves can see the pattern of their diaries and have a bit more ownership of the condition. And of course, guidance on all lifestyle factors, sleep and stress reduction. And more importantly is the long-term follow-up and the coordination of care. And then, like I say, usually, after one consultation, once you've confirmed that, yep, we're dealing with migraine, this is why you possibly have it, I'm not quite sure, but, and once they understand, then you have that engagement, and then you have the follow-up, until there's a bit more control with the condition. So yeah, an average sort of day, so a clinic day, obviously varies from day to day, but a lot of the time, as I mentioned at the beginning, is triaging new referrals, specifically advice and guidance. And it's really good to see that being used, the advice and guidance, because it means that, like I said, you can almost give a treatment plan electronically, and then that patient's able to be treated appropriately, prioritize the urgent cases, and we plan clinic schedules. And a lot of the clinics involve first consultations in my case, and a lot of patients have been sort of 20, 30 years suffering with headaches, and they're finally sitting in front of me, for the first time, understanding the headaches and migraines, and it's quite a breakthrough, really. You're always developing a personalized care plan because everybody is so different and how they respond to treatment. So, in that way, you're optimizing the preventatives and their acute treatments. And like I say, you treat patients holistically. Not to forget the mental health as well, because it does take a toll. Mental health, work life, and social life. We also offer all, if not most, if not all of the injectable treatments and the newer treatments. So botulinum toxin, the monoclonal antibody treatments, greater occipital nerve blocks, which are very commonly used. Of course, it helps if you, as a nurse, being an independent prescriber. We've also recently developed a nurse-led lumbar puncture clinic. Now, this is for non-urgent cases, but this is really useful for those who you suspect IIH, intracranial hypertension, but it's quite a nice service to be able to offer. And as a headache nurses, we're delivering advanced treatments, and at the end of the day, we're helping patients access care faster, because that's what we want. We want to speed up the treatment pathway and have this seamless care as well. And we must remember that headache care is multidisciplinary. Not only nurses, but we do work with psychologists, or I do, and we're also trying to link with pharmacists, who are vital, I think, in helping with treatment, especially treatment advice, because when a treatment isn't working and patients do go to the pharmacist for more treatment, then it's the pharmacist that they see first. So it's really good to see that pharmacists are taking an interest in headache, and I can imagine that's going to increase in the future. Education, support and service development. Again, education is priority. Like I say, once the patient understands the condition and engages, then you've got a far better chance of controlling symptoms. I quite often deliver training for local, so GPs, primary care centres. I wish I could do more and wish I could get to more places, because I do find it helps, and I get brilliant feedback from primary care, just learning more about migraine and how they're going to put that into their own practice. It's really nice to hear. And I often contribute to headache pathways and obviously ICS strategies. Goes without saying, involved in service audits and research. So beyond the clinics, our roles as nurses include education, service development, and obviously research and improving access. That's the main thing. It's improving this access that patients need to reduce the inequalities in headache care. And beyond the clinic, we are leaders. We are, as mentioned, leading migraine clinics, which is really, really good, and service development. And it'd be great to have more nurse-led clinic hubs around. And we're also very heavily involved in research, education, and advocacy. Unfortunately, there are challenges, as with everything. That we do have, as nurses, limited formal training. This is obviously the migraine stigma. Not many nurses or healthcare professionals are ever taught about migraine in the sort of student era or at all. So it's time to change that, and this leads to resource constraints. But there are opportunities on the horizon, and we can see that there are new treatment pathways emerging, got integrated care models, and we are leading innovation, and hopefully new education frameworks will be on the horizon too. So if we're looking at reflections on setting up similar headache care pathways nationally, we need strategic planning and leadership, and national alignment must link in with the NHS England's long-term plan and integrated care systems. And again, as I mentioned earlier, embedding with the Getting It Right First Time, the GIRF Neurology programme, to standardise pathways and not have this inequality. We need to understand regional headache prevalence, the existing capacity and the access inequalities. And for rural areas, we need to design care models to reduce travel and bring specialist services into the community. Clinical champions would be a great idea in each area, and we could identify headache nurse consultants or neurologists to drive and service redesign locally. So the workforce development needed would be to expand the role of the headache nurses and recruit and retain, if that's more importantly, headache specialists. And upskill them in prescribing, ideally, so that they can deliver all the advanced therapies and provide basic assessment and diagnosis for patients. Interdisciplinary collaboration is paramount. Like I say, it doesn't have to be nurses, it can be physiotherapists, pharmacists, and integrate in primary care, secondary care, and within pain services, and of course the mental health teams. And use the multidisciplinary team model for more complex cases. I find mental health is difficult. I've had a patient who has struggled to even have the support from their mental health team, and it's kind of like, oh well, you're under the migraine service, that's enough. But a lot of the time patients need a little bit more psychological support, because everybody's different in how they manage their sort of chronic condition. Training and education goes without saying, and like I mentioned, there is a national training framework for headache nurses led by the Royal College of Nursing on the horizon, and to be published very soon. So infrastructure and digital enablement, which of course clinic capacity, if we could set up local headache hubs within community hospitals like Penrith, we could equip them for advanced treatments, and then they'd be able to administer or offer even nerve blocks would be a massive step forward. Virtual clinics, of course, expand digital consultations to reach rural regions, because a lot of the time patients are travelling, some even travel over an hour to Penrith. Well, why is that? And, you know, so we need to sort of integrate maybe remote monitoring tools for headache diaries and treatment response, electronic referral system integration, yes, ensure seamless e-referral pathways from GPs to headache triage hubs. And it goes without saying, data and audit collection, you know, collect standardized headache outcome data so we nationally just to measure impact. Commissioning and funding, well, ideally, services should be designed and funded at the integrated care system level for consistency, and evidence-based business cases. So we're demonstrating that we're reducing hospital admissions. A lot of patients attend A&E with a really bad migraine, and time again, they do readmit, and we need to lower that. And we have found that having a headache nurse clinic just for somebody for that support, lower, you know, once that patient has had the diagnosis and is educated, you see a reduction in A&E and hospital admissions, and obviously improves satisfaction and cost efficiency. So advanced therapies delivered locally, reduced tertiary referrals, and then freeing capacity in major centres. So it is a knock-on effect. And as Sue alluded to earlier, it's aligning with the NHS 10-year long-term plan. So the focus is on integrated community-based care, so shifting care out of hospitals and into the community. So replicating little hubs such as the Penrith and you know, around more closer to home for patients. It's preventative long-term condition management. So we know persistent headache and migraine is chronic. It's a chronic condition. We can lower symptoms, but we know there's no cure for it. So, you know, the plan emphasizes better management of long-term conditions, but ultimately reducing hospital admissions. The investment in technology and innovation. So we have NHS funding novel devices. There's neuromodulation tools available. So that would be really helpful for patients to have, and headache management to widen non-pharmacological therapeutic options. And we've mentioned a lot about health inequalities. So it's innovative pathways, ensuring more consistent access across regions, which supports the plan's goal of reducing geographic variation and avoids patients having to travel so far. And it would be better use of staff and workforce. So workforce sustainability and new roles. So like not just with headache nurses, but as I mentioned earlier, physiotherapists and pharmacists, expanding roles and specialist pathways. And efficiencies contribute directly to this workforce agenda. So to replicate the North Cumbria Integrated Care model, we would need a visionary leadership. We need investment in specialist nursing and integration between primary, secondary and tertiary care, because with structured referral pathways, nurse-led clinics, physiotherapy, you know, led clinics, and local access to advanced therapies, we can tackle inequalities, reduce waiting times, and improve patient outcomes. Thank you.
Thank you very much, Yvonne. That was fascinating, and I'm sure has given everybody a good idea of how you can actually utilise the skills of a headache nurse consultant and the multidisciplinary team as well in terms of managing that patient pathway. So thank you for that presentation. We've got some questions here that I'd like to ask you, but just to start off, there's research evidence that physiotherapy delivered manual therapy is effective in treating TTH, cervicogenetic headaches, and in some cases migraine. Are there any specialist physios nationally in these clinics? Have physios historically had any input into this care pathway? So that's a long question for you, Siobhan, if you could give me
No,
any thoughts on that.
yeah, it's a really good question. We do have a couple of physiotherapists within, we call us the headache nurses, but we do have some physiotherapists, pharmacists, and lots of health professionals. And yeah, one in particular, she will see migraine patients. We do a very similar way of assessing, treating, and diagnose, and with regards to, say, for example, cervicogenic headache, yes, I see cervicogenic headache, and usually, not every time, but usually the nerve block, for example, is an option. And I'm almost sure that the physiotherapist I'm thinking of will do that. For example, she'd be able to treat that using that, so the nerve block or other preventative means. I would say there isn't enough physiotherapists interested in headache as in pharmacists, and it would be great to attract physiotherapists as well, because they can offer, with their background knowledge, so much more in terms of, you know, sort of pacing. So is one example, sort of lifestyle, and exercise, movement, a bit more, which all helps reduce symptoms. So, but yeah,
Thank you. Thank you. We've got another question here that says, how long is your patient assessment slot for new and follow-up visits? And are you able to order investigations if required?
So for a new patient, 45 minutes. And in that time, if they did need a treatment, I potentially could give, like, for an example, a nerve block. For follow-ups, that could range between 15 and 30 minutes. And yes, if I feel there is a need to order imaging, for example, I do run it by a consultant sometimes, but yeah, I'm able to do that as well. Yeah.
Okay, thank you. And another one here, how do you identify non-headache migraine patients?
Non-headache. Do you mean
Yes.
do you mean those with sort of other associated symptoms, maybe?
Yeah,
Or...
I suppose the
All right.
question means that. Yeah.
Again, it all falls down to that first consultation. I mean, you know, I don't assume it's migraine. I mean, yeah, they're coming in with headache, but again, I do a very thorough history taking to come to that sort of conclusion, and yeah, from that, so it all goes down to the consultation, and then go from there, really. I think that's
Okay.
yeah,
And
yeah.
a quick last one as we're running out of time. Are you managing and then directly referring patients to tertiary centres?
If required, it's not very often, but yeah, if it's a extremely complex case, I mean, it could be migraine, it could be facial pain, it could be, you know, so it all depends. But I do ask my senior for advice in the first instance, first, but then if needed, we do have Newcastle, yeah.
Excellent. Okay, thank you very much. We've run out of time. We've got more questions, but we've run out of time. But very good presentation, and thank you very much for that, Siobhan.
Thank you.
And thank you to everybody for attending. I think it's been a really useful start to the kind of the whole focus on headache from the Neurology Academy.